Okay, hello everybody. Thank you very much for joining us this evening. We have a special treat, some continuing education to help us fit specialty lenses better and improve our practice. And we are delighted to have all docs friends and members here to give us this education. I will get to their introduction in just a moment. But I wanted to thank you for coming. So without further ado, I will introduce our fantastic speakers this evening. The very prestigious Dr. Sheila Morrison, who is an Alberta-based optometrist, educator, and residency-trained specialty contact lens fitter. She holds a doctorate of optometry and a master's in vision science, along with a cornea and contact lens residency from Pacific University. After serving as a clinical professor at the University of Houston, she joined Mission Eye Care in Calgary, where she is a supervisor of the cornea and contact lens residency and teaches as adjunct faculty at NSU Oklahoma, a fellow of the American Academy of Optometry, Scleral Lens Education Society, and Canadian College of Specialties in Optometry. She's also an awarded member of the International Society of Contact Lens Specialists and a trustee for the Canadian Optometric Education Trust. We also have this evening joining us our very own Dr. Sam Dhaliwal, born and raised in Edmonton, graduated with cum laude honors from the Illinois College of Optometry, where he also earned a Bachelor of Science degree in Visual Science. Dr. Dhaliwal is an accomplished optometrist with extensive experience in ocular disease management, particularly corneal diseases like keratoconus. Over the years, he has refined his skills to achieve optimal fits, helping many patients with keratoconus and other corneal diseases see their best. So thank you both very much for joining us and giving us this education this evening. I will turn it over to you. Thank you again.
Well, thanks so much, Tara. We really appreciate it. And for me personally, Sam is just kind of down the street from me in Edmonton. I'm in Calgary. So both here in Alberta, and it really is always a pleasure to work together. I know what our plan today is really to go through a couple of objectives. There are some of you out there that are fitting a lot of lenses. Some of you out there are not fitting many lenses yet. But the reason that we're on here is to start to learn a little bit about that pathway and specifically how do we in our clinical practices improve our efficiency, get to faster fits, better fits faster, and specifically when we're looking at using ocular surface profilometry. So some of our objectives today, we want to look at how do we understand the ocular shape? That's the basis of how we fit medical contact lenses, is always starting off with understanding the shape on which we place that little piece of plastic. Because if we understand that shape first, then we can more easily make decisions that will result in more effective choices. We're going to teach you a little bit about what is corneo-scleral profilometry and learn techniques for designing precise scleral lenses. We're also going to jump into HOA correction. So that's a really cool and exciting area in contact lens fitting today, where we are now able to use high-level technology to really elevate what we do in the clinic. Those patients that used to really kind of run out of steam, where we could get them to a certain level of their vision and say, hey, I'm sorry, that's as good as it can be. We have higher levels and bars that are higher and higher than ever before. So overall, we want to share our practice pearls. We want to teach about the technology and open up a section at the end that will have time for questions. Now, starting off, we wanted to kind of paint a picture. So the first area in this presentation is challenges in modern contact lens fitting. And so one of the things that is true is that we really lack really good data on what is the true ocular shape. Traditional topography misses a lot of the eye. So if we're looking at topography-driven lens design, a lot of the units historically that we've used will capture only a central area of the cornea and extrapolate the periphery. So that presents a real big challenge, especially when we're not trying to fit the cornea anymore. We're fitting scleral lenses, looking to vault over that surface and really jump outside. And so two problems: one, a lack of literature that teaches us exactly what eye shape really is on the average patient. Is there a correlation to a certain condition? Like, do keratoconus patients always have a certain scleral shape that could help us to make it easier when we're making decisions on what shape of lens should we choose for a patient with keratoconus versus a patient with the astigmatism or, spherical with dry eye. And the reality is that the cornea shape and the scleral shape are really not related. They can be similar. They can both be with the rule. They can be opposite. One could be regular and the other irregular. And so it really is something that we've learned over time with this technology, is by measuring, we can accurately get a good picture, not only of just the cornea, but outside of the cornea. So when we're fitting scleral lenses, we can make better choices. Now, overall, all of us are out here to A, do a great job for our patients. B, we have to do things in the clinic that actually make sense. And that's where Sam is going to come in to really help to give us a picture of what he does in his clinical protocols when it comes to technology and data-driven lens design. Because I'm going to let you know right now, there's many different ways to get to the finish line when we're fitting contact lenses. There really are. There's a whole variety of different techniques. And, we can go two different pathways. We can use a trial and error fitting style where we will, put a lens on the eye and look at what that looks like and make adjustments from there. Sometimes this can result in a longer fitting process. And so in the efficient style, we'll say evidence-based contact lens fitting. By taking data first, we can then shorten our chair time by building in algorithms with our staff so that we can teach our staff how to use data, pick lenses. We're going to go through that today. And overall, our workflows are improved with technology. And technology is really here to stay. It's not going anywhere. And so, early on, I think Sam and I have both been really early adopters, truthfully, in our communities. I know, how long have you been using corneal topography for in your office and ocular surface profilometry?
I think topography, 15 years. I think
Yeah.
I've
Yeah.
two med months now, and I want to say about 3 years I've been with the eaglet, maybe four. So yeah, pretty
Which is
early.
which is an early adopter in Canada. This technology is kind of making its way largely from the US, and we'll teach you about different tools that are available. And it's certainly, over time, we've both definitely found that technology has been a way to improve our efficiency and workflows.
Absolutely.
Now, we got problems where we're running into issues if we don't understand ocular shape well enough. It can be a little bit cumbersome to fit contact lenses using the trial and error style. And the solution to that, truthfully, when it comes to evidence-based contact lens fitting, can start with ocular shape. And so this next section is going to teach sort of what it looks like to measure the entire ocular surface using elevation data. And I want to highlight the point that elevation is really the measuring tool that's the most important when it comes to looking at the shape of the structure that we're going to put the contact lens on. Curvature can go forward and backwards, whereas elevation is a true height based on we'll say a best fit sphere. Something that's highly elevated on the eye is going to be sticking out further. And as a lens comes toward the eye, that's the point of first contact. And so that's why measurement of complete ocular surface and looking at elevation as the primary measurement is the starting point for me and for Sam in our clinics when we're looking at what style of lens do we want to use? How great of a height difference is there on that eye? What design of a contact lens will we have to choose? Because manufacturers all have different parameters within a scleral lenses and other lenses as well. Now, this is an example of the corneal topography versus ocular surface profilometry. And you can see there's a big difference here in the amount of data that we get. Whereas our cornea gives us wonderful information if we're fitting a GP lens, a corneal GP, fitting a custom soft lens. Ocular surface profilometry expands and gives us not only the corneal shape, but also the shape of the sclera and that tissue that's outside of where the lens would land. Now, one of the things I'll let you know right now is that ocular surface profilometry is very much capable of measuring the cornea just as much as the sclera. So I guess, historically, when this technology first came to market, we really considered these tools, ocular surface profilometry, as more of a scleral lens fitting device. And what we've seen over time as technology continues to get better, and not only the ability to measure, but also the ability to transfer that information into lens designs, is that it's measuring the cornea very, very accurately too, which allows us to really clearly understand the ocular surface. So I'm going to teach just a little bit
Yeah.
about some of the basics. And I see, Sam, your hand's going up like in a
Yeah.
classroom, which is
And
perfect.
I was going to mention like that image you had up there on the corneal topographer, like that's a great image for maybe earlier or even moderate keratocones, but the more advanced you get, sometimes you can't even get a scan like that. So you're really starting with very little data, and the more data you obtain, the workflow just goes so much faster. It's better for your techs, better for your patient. So there's a big difference between these 2 points. Like, this is the way I like to describe it: is the corneal topographer really gives you like just a 2D scan, whereas the corneo-scleral proliferometer gives you more of a 3D scan, right? A better starting point.
Absolutely, gives the whole
Yeah.
picture. So now, by understanding that ocular surface, another kind of thing that we use the technology for, when we look at the height of an eye and measure the elevation based on a best fit sphere, we can then generate what's called sagittal height measurements. And that is what this picture is here to kind of orient us to exactly what does sag of a lens mean. if we were looking at a lens that has a larger diameter, let's just imagine the bottom longer line is a larger diameter lens. The height to the front of the eye is deeper. That's a higher seg. Whereas a smaller diameter lens that has maybe, we'll just look at that top line, has a shallower seg. And so a big advantage of taking these measurements early on is to be able to appropriately fit an eye with an appropriately seg lens. And that holds for sclerals. That's the primary indication, or the primary place that we use this information. We also see a resurgence of custom soft design that's starting to become more advanced. It's things that people have been talking about for a long time in fitting the sagittal height of the eye rather than base curve. And the ocular surface profilometer is very, very capable of collecting this information. Now, this is an elevation map. And again, just to kind of reiterate and show some nice pictures to give an idea of what is capable when we take these measurements, is the elevation maps that these tools will generate creates a really great 3D shape of the eye, and using a best fit sphere to compare relative eye shape to be able to choose the lenses. Now, bi-sphere elevation maps are pretty cool because, as you may recall from Anatomy 101, we have a different curvature on the cornea, and it kind of flattens out and changes at the sclera. And so the way that this technology works, just to kind of get to the end of what our orientation to what the images are that you're looking at, the ESP and a lot of our ocular surface profilometers will compare eye shape to what's called a best fit sphere. And we actually use two different spheres to compare this to, meaning that the corneal data is slightly different than the scleral data. And it becomes very easy to understand when we look at these maps. Okay, so next let's dig into what do the ocular profiles look like. So this is where we start to get into what do we see in the clinic when we take images. These are classic corneal profiles that we've all seen in the clinic. So we have pellucid, starting at the top on the left. We have a central cone and keratoconus, post-LASIK, pinguecula. You can see here that those corneal shapes vary, and so does the sclera. And so just to give you an idea of what some of these things look like, moving down, when we look at paying more attention to the scleral toricity, we have on the far left scleral shape that looks highly irregular, although if you look at the vertical meridian, that shape is very similar because it's in blue. It's very similar, almost like we'll say a with the rule scleral toricity. We also see examples of against the rule in that next image on the right-hand side, and then oblique, where our toricity on the scleral is completely at an oblique angle. And then irregular shape is beside it on the right-hand side. Imaging is capable of taking all kinds of lumps and bumps and turning them into these maps so that you really get a good visual of exactly what that eye shape is. Cool, and on the bottom right is a filtering bleb, and those guys are just, gnarly in the clinic when we take a look at how could we begin to fit a lens on an eye that has this huge big lump or bump. And we can actually localize and position exactly where these bumps are using this type of scanning tool. And it allows us to then go into software and lens design software, and create lumps and bumps in the exact same spot that's a mirror kind of 3D print for the eye, which is very, very cool. This is a fun one as well. So I think, Sam, we've talked about some of these cases in passing over time, and would both probably argue that, I know you certainly would, that one of the primary indications when we're fitting scleral lenses to go from a standard design into a freeform would be a lump or a bump like a pinguecula. Do you want to comment at all on this, on what you see in the clinic in regards to these lumps and bumps, and why is it hard to fit in another design? How does it help to get an eye shape scan first before we fit?
Oh, for sure. So just on that last slide that Sheila presented, like that information that that I see before even walking to the room or seeing the patient gives me already an idea of what lens I'm going with. Prior to this, if I just had a topographer, I would probably approach every patient the same until I actually get a look at the slit lamp and see what I'm dealing with. But this information, saves so much time, gives me an idea of where I'm headed, what direction with the patient. And then the next page, these two are the most common type of patient I see that are very, unsuccessful at other clinics and find their way into my practice. The pinguecula and the trab, just because majority of conventional scleral lenses, it's very difficult to have them symmetrically settle on a sclera when you are dealing with a bump like this, right? You're going to get some pinching, you're going to get some blanching. It all leads to either a red eye or uncomfortable eye, right? So cosmetically, it doesn't look good to the patient, and they don't feel good. So whenever I see something like this nowadays, I'll lead straight to a more customized lens. I really won't even consider conventional scleral lenses. One, I know the patient will benefit from it, but secondly, it's too much chair time. Trying to, you're trying to do something that just can't be done without, either creating, like a funnel or notches. I can't
No way,
remember.
those pingueculas are gnarly. So it's, I know what you mean. It's half the time when you create, some kind of vault over a lump. If you take a look at that picture on the left,
Yeah.
if you put a bump in there, half the time there's a little channel with air bubbles getting in, and you have to adjust it again, and then something's pinching over here, adjust it again, and then so forth. So I'm with you in that camp that it really is a huge asset in digital lens design to go ahead and create a curve that just jumps right over it right from the start. So we don't have to spend that time fussing around with that lens as it's being finicky. The other thing about when we make these changes on these lenses, every time you make a change that's trying to either do a notch or a bump over a pinguecula like this, the lens might rotate differently. And then all of a sudden there could be a power change that we're trying to chase too.
Mhm.
So again, kind of cut to the chase. I agree. I think that this is one of the greatest indications as well for utilizing ocular shape to then either place something like a microvault or go freeform right off the bat. It's a wonderful solution, and I agree fully with you on that one.
This would save, easy 2 visits, right? And the way I could look at a visit is it's almost 2 hours of a patient's life, right? So
Time will never get back. Time's ticking. Time is money these days.
yeah.
Really is. And if you're going to differentiate yourself from competitors, truthfully, patients are waiting too many minutes or hours in the clinic and also coming back for repeated visits. I have this happen, and it's just, it becomes, you joke around and make the best of it and say, hey, you're a frequent flyer here now, you're VIP, trying to make them sound like it's really special that they're in the clinic 9 times because you
Yeah.
can't get their lens quite to fit perfectly. So it really is the way that our, direction is headed, very analogous to, ortho-K fitting, having an option that is based on shape. It just takes a lot of that guesswork out right from the start and allows us to focus on the higher level stuff, which is, patient goals, what their vision, what they want their vision to be, and how do the modalities we choose fit as tools in their life, so that then they can optimize those little details for sports for one set and do something else with something else. We're not spending time fixing a lens 20 times so that then by the point we're ready to optimize, they're already kind of checked out and ready to go.
Yeah.
Now, curvature and elevation are kind of cool things that I kind of lightly started to talk about a little bit. And it's, again, a major lesson of as we're learning how to use topographers, not just profilometers, but any kind of ocular surface topography. And that corneo-scleral, all of it, curvature versus elevation. And that's a difference in how we view the maps. Our axial power is a curvature map, whereas and tangential is a curvature map, whereas elevation is a real-time actual, what is the shape? And so that arguably would be the most useful when designing lenses. Now, some of the limitations, if we look at curvature versus sagittal height, if we're looking at that number one side, the non-elevation map, the curvature map, we're really looking at not the true shape at all, but that curvature that could go towards you or away from you. It certainly misses asymmetries. And as eyes get more and more complicated, it really poses a big advantage to switch over and get a full elevation map, and not only just of the cornea, but the whole ocular surface, just so that we really understand what we can expect when we put plastic on the eye. This is kind of cool. So this is 3 different curvature profiles, and it's actually a very, very great example of exactly what Sam and I wanted to communicate here, in that curvature is curvature. These eyes all have the same curvature, but look at how dramatically different that shape is. So if we're fitting based off of traditional topography styles and using that to fit scleral lenses, or using that to fit our lenses that land on the peripheral cornea and land on those lumps and bumps, we're going to fail every time. Really, the only way to get the true shape to design a lens to fit on top of that is to look at elevation. Now, as we kind of zip through this to make sure that we have a lot of time for questions from everybody, because a lot of the practice management side is what we really want to make sure to have time for. A lot of you are business owners, a lot of you are, active in the community doing things either just for your practice, but also for this, the whole group. Our community is very tight knit, especially this one. And I know that a lot of you are going to be really excited to talk business at the end, and so we'll make sure we get there. Now, when it comes to that relevance, again, we understanding the height of an eye and the sagittal height of the eye allows us to then go into our fitting set and pull a lens that's the right height. In fact, if we're talking about workflow and really tying in the technology to what is practical in the clinic, I'm going to ask Sam to go ahead and give us a bit of an idea of the workflow of how do we translate At what order do we take measurements, and what do you use the data on sagittal height for? You're always doing freeform, or do you pull trowel lenses from that? And then I'll share my workflow too. Although I don't know if I can add much, because I think, we're probably, I'm guessing we're probably running a fairly similar workflow at this point, but maybe I'll have a few extra things to add.
Sure. Prior to me, acquiring the eaglet, our workflow was, vastly different. Our patients would be booked in for, new fits, an hour, follow-ups, 45 minutes maybe. Since we've had a chance to, start using the eaglet, we've got our workflow down to about new fits 30 minutes on the doctor's, schedule, 15 to 30 minutes of follow-up based on the patient. We inform patients to, allow themselves about 2 hours in our clinic. They come in 30 minutes typically before before they're on the doctor's schedule. So they come in 30 minutes to spend time with our technicians collecting preliminary data, which includes corneal topography. I still do corneal topography, but then we also do the corneo-scleral profilometry. We do some autorefraction, fundus evaluations if we need to. But by the time the patient is in, my chair, my technicians have already kind of got an idea of what the first fit lens is going to be, just based off the eaglet platform. A lot of times, if I know the patient, I'll just have them fit the patient themselves, and check if there's any bearing. And I'll see them back after 20 minutes of settling, or 20-30 minutes of settling. So in most cases, I don't even see the patient for more than 20 to 30 minutes max. So that allows me to see other patients. Less chair time for the patient with me. I found that has worked very well over the last few years, and I've shared my workflow with other doctors, but without the eaglet, I just can't see my workflow being that efficient.
Totally. We have some images to share, some other kind of cool things. So if you kind of take a look here, just to kind of touch back on what this slide is intended to share, is really the importance of generating that information that Sam is taking at the beginning of every fit. We're understanding the height of the eye so that we can appropriately vault, so that we can guide that haptic, and so that we can really reduce the chair time in the end. Now, this is kind of a cool picture looking at, here's a patient, live patient, and we can see based off of our imaging, the imaging is very, very accurate. If you were to turn this thing on a cross section, it literally will look like the OCT on the bottom. The data is very, very clear, and it's, when we use the data to design lenses, it becomes a lot easier to accommodate shapes like this, where we have a lot of asymmetry in the vault beneath the lens. An eye that has a really steep point in the center is going to be really close to the back surface of the lens, and whereas there can be mid-peripheral excess that you see adjacent to the blue arrow, and really using tech to design lenses that more smoothly fit that shape has really improved our fitting speed. We use this in soft lenses too, so we threw this in there just to highlight how cool it is to build custom soft lenses as well. Again, SAG varies. I don't know if there are studies that have been done, largely out of Pacific University, that have shown measurements of all of our conventional, commercially available contact lenses, our dailies, our monthlies, everything. And the reality is that there's a whole variety of SAG heights that are out there, and they are not listed on the packaging. And so when you look at patients that are non-successful, most patients, you can put a lens on the eye, and it's like, okay, wham, bam, done. And most people are happy in just a standard lens out of a box. The ones, that population that tends to drop out of lenses, usually if you look carefully at the data, if we went and measured their eye shape, there would be a mismatch somehow between that lens shape and their eye shape. And so utilizing SAG really helps to eliminate that. Now, ortho-K is possible as well with profilometry. So we traditionally think of fitting ortho-K lenses with corneal topography only, that really just has the map of the central cornea. Still works like a charm. Honestly, we have both in our practice, and so does Sam. However, we wanted to highlight and point out that you can use all this technology. Say if you only have one topographer, you're getting a corneo-scleral profilometer for the first time, don't have another topographer, you absolutely can use this technology to fit ortho-K as well. And so another thing to highlight in that is that in some reports, it can be actually seen as an advantage to use fitting styles based off of elevation because that's more of a true shape of the entire cornea, including the periphery. And so these fits work out just fine. It's another use for the tool and another way to kind of, if you are limited in space, you're getting equipment that you don't have a topographer, you can use one thing for everything. Now, in practice, there are multiple devices that can do kind of the same thing. They're not all equal though. And so what, the best thing to do, truthfully, is to start to kind of get a feel for what is available for you with manufacturers that you like to work with. And, some of these tools that you see are going to be specific and custom just for one particular lens. So to be clear, some profilometers are going to be partnered to just one lens design and one lens design only. And that's okay if that's the only design you use. Some profilometers are going to be compatible with a whole variety of different manufacturers. That is one thing about the eaglet that's a little bit more unique, and that I have enjoyed over the years, truthfully, because it does not restrict you from working with labs that you want to work with. And so to give an idea, on the left, these are two examples of profilometers that are reflection based. That means we put fluorescein on the eye, reflect light in different angles, and it will give a reflection image. It's profilometry. Then we have our Scheimpflug imaging, which we're familiar with the Pentacam, and then another reflection-based system on the far right. Now, profilometers, this is another output just showing kind of examples of the way that the software will create maps, and they all look a little different. So it's really key, whatever tool you're using, is to get familiar with what those curvature maps, what the colors mean. Is cool high or is cool low, and just get comfortable reading that map for your unit, because ultimately they all kind of measure the same thing, but they will display them in different ways. Now we can get a full scan of the eye. We know that. And at the bottom, at the end of the day, really has allowed us to kind of embark into this empirical fitting era, which has been a lot of fun for us to find solutions for people. And the cool thing about fitting based on shape is that it's not just reserved anymore for eyes that are just train wrecks. We can actually, in our practice, we do a profilometry scan on every single patient that comes in for a contact lens fit, a medical contact lens fit that we know we're thinking of putting a hard lens on or a scleral. And what we've found is that, the technology is equally useful on an eye that's very normal shaped with regular astigmatism, if you're putting them in a scleral, for example, as it's useful in an eye that is highly irregular, maybe from a corneal transplant, keratoconus, or something else that's gone on. So custom lens fitting is really now, and it's here to stay. And it applies to every lens, every eye profile. It's not just for the really difficult eyes anymore. Are you measuring on every single contact lens fit as well? It sounds like in your workflow you do.
Yeah, we do. Yeah, just because you don't know what what lens we're going to go with, so we just assume every patient's a custom
And you
lens.
can't tell by looking at somebody as much as you think you can by looking at or reading their diagnosis. Okay, keratoconus must be just this wild scleral shape. We got to do freeform. We got to do crazy impression based. And then you do a scan and look, and they're like the easiest fit on the planet. Run of the mill, easy sclera, no problem. And then you'll get some patient that, you would think would be easier, and it's just not. You cannot tell by looking at somebody. You cannot tell by understanding the cornea shape. The only way you can tell is by measuring and looking at that data. So digital fitting process has allowed us to really streamline. And so Sam has shared his, and I want to jump in and kind of share. It sounds like we're really doing mainly the same things. One thing I'll add to, and I'm sure that you do this as well, is we really try to get a good understanding of retina health before we go into a contact lens fit. As much as we have all these bells and whistles to measure the front of the eye and build lenses that are just like, amazing, if there is something hindering vision, you can end up with a very disappointed patient if it turns out they have a macular hole or something. And so it's very important to understand retina health and what their best vision could be. Pinhole is very useful, although in highly irregular eyes, it can be very difficult to do a pinhole when they don't have a hard lens. You're not going to get a great result and get their best vision with pinhole if they have very advanced keratoconus and it's just completely crazy. You're going to have to do a pinhole over some form of a hard lens to really get that, but that will allow you to differentiate and get a best acuity potential estimate, and therefore move forward with setting expectations. Now, we love this slide, and not just because it's very beautiful, it's a very pretty slide, but because it has just so much in it that is just so true to our hearts, because I'm out there all the time. I'm a contact lens junkie. I absolutely love talking with my colleagues and learning what everybody else is doing, trying to stay up on all the latest technology. And because of that, I've been an early adopter. I've worked at schools. That gives me bells and whistles. And then come into private practice, not everybody has all the bells and whistles. And some that have been fitting for a very long time would argue it's more of an art than it is a science. I could fit a lens on anybody with a diagnostic fitting style. And the truth is, They probably can speed walk past the finish line, you know, whatever works. But on average, the science is here to stay. And the very best way to do our best and the best results that I get really come from the merging of art and science, where the science does not replace our intellect. The science does not replace putting trial lenses on to get best power. You know, to go on that note, remember that with irregular eyes, we cannot empirically design from start to finish with this technology. We still have to put a lens on if it's our first time fitting them to be able to actually refract in most cases. And so these science and art need to go together. But the really beautiful thing, not just because it looks beautiful on this slide, but the beautiful thing about science is that by cutting out steps, making our chair time faster and more efficient using technology, we then can actually have the time to spend on those fine-tuning moments of art, and science doesn't replace it. So spending time with forums like this to really learn about the proper ways to fit, it still is something that you're going to have to do, because as much as we can spit a lens out based off of a shape, you still have to understand what to do when there's a complication, still have to know how to adjust that lens if things just aren't working right. But the reality is, when we fit with science, those train wrecks and those difficulties happen a lot less. And I'm going to say that's absolutely the case. You know, those complications of fitting finicky things are just so much less when we start off with science. Now, the diagnostic set process, you know, as my residency director told me, if you're unsure of what to do, you just get a lens in the middle of the set and stick it on the eye. And you know what? Whatever. Sometimes we do that and that works. Now, challenges, of course, sometimes it can take a few more steps. It can be a steep learning curve depending on the lens modality that you're using. But overall, this is still a path to the finish line. Empirical is really cool. So we know our steps. So Sam and I will take our patients, we know their retina health. Then we'll take every patient through this whole battery of understanding ocular shape, and we have to have the technology to do that. So we do triad glasses refraction on everybody, even though they might come in and say, I can't wear glasses. No one can put glasses on me. We still try. Then we're going to do a full profile of ocular shape and determine what is our best modality. Do you have kind of a rule in your clinic if you look at ocular surface profilometry of like, how would you choose if you're going to put somebody in a corneal lens that's hard or just go straight to a scleral?
That's a good question. You know, it really depends on, you know, what their experience has been with contacts. Like if they've tried them in the past and they're absolutely not willing to go back into, you know, a scleral lens, that just that
Right.
the whole insertion removal is, you know, a nightmare to them.
Totally.
It's usually when I'll go into a GP lens.
Yeah. And then it's funny you mentioned that, because I don't really actually, I'm not active on any of the online forums, but on Facebook, it's like keratoconus, like where patients comment. There's this active one right now that was posted today that's about like patients saying to each other, I'm never going to go back in scleral lenses ever again. And it's this whole big thing of them all just, you know, cussing out sclerals and talking about that handling issue. And then Nate, one of our colleagues who fits a lot of contacts, commented and said, look, you know, there's other options then. And to your point, that's where you throw them in a piggyback or something like that and throw a hard lens on as well. Another way that you can choose between a corneal lens and a scleral based off of data is look at the elevation again. So if that elevation difference is too great on the cornea and we're trying to put a corneal lens on there, it may just rock off. And if we see that the elevation is very high, highly different where the lens would land, we just say, I'm going to skip it and I'll just put a scleral on and jump right over it. So again, with empirical fitting, we still need a power from usually if we have a patient that had a lens on in the past that was hard, you can empirically fit a scleral lens from an ESP or any other profilometer, get the shape from the device, measure or pull their old GP parameters even from their corneal lens and just build it into the lens. I do that all the time. If I'm feeling lazy, I don't want to take more measurements that day. I see they had an old fit from, you know, last year. It was okay. I'm going to just digitally order the lens, empirically done, not spend time on it, order it with the power from their last design, of course, the lab, or you can do dust off the cobwebs and sandfap it if you want, whatever. And there you go. There you've got your lens without any time spent on trying to redo it. And then I find that's actually for me more effective. And then on the second visit is where we'll spend more time refining that power.
Well, that's why it's so important to just take those scans at you know, every fit. Yeah.
Love it. This is a patient who's 20 years old. Kind of cool OCT images. So clearly we can see that we've got advanced keratoconus and hydrops. Hydrops is on the right eye. You can see that by there's a little tear at the back of Desmai's membrane back here, this little flap. Can you see my mouse moving?
Yep.
Nice. So yeah, so this is a patient that failed fit. So this is our opposite of what we had discussed a minute ago, where somebody came in and couldn't wear soft lenses or hard lenses because their eye was so irregular in shape. So diagnostic fit, to give you an example, this is literally the clinical flow of the lens fit. So you order something, start with something, it's okay, change the power, change the fit. So 5 lenses later, we get to this beautiful lens. It looks great. Took a few steps. Here's our path with profilometry. How sweet is this? So we can actually now bypass and skip all those steps. And I find that depending on the scan quality, it is usually very accurate. Sometimes I will have first lens fits. Sometimes I will have one adjustment. Very rarely do I have 5 adjustments. And so it really is a huge asset to go ahead and use the software. And this is a kind of a cool feature that I'll use in my clinic with patients that get scanned with all of our equipment. As they're going into the next room to get seated, I'm shimming in here just to kind of look and see what the profile is so I can pull these lenses. My staff are trained to use the algorithm in the software that will actually select a starting lens out of your trial set for you. It's like you don't have to think anymore. And my staff can do that. And I think, Sam, that's what you were saying that you do too, is by the time you get in with your patient, staff have already looked at this information, selected first lens fit, chose their scleral that they want to work with, put it on the eye, and it's usually pretty good. They'll do the OCT. It's usually 200 microns clearance. Away we go. So it's a really, really useful and effective tool for getting to not only a digitally created freeform lens, but also if you want to do fitting style, good for you. I fit with a diagnostic fitting set all the time, but I always look at the ESP or the profilometry so that we can actually pull a starting lens a little quicker and just get it on the eye and not spend time on it.
Hey, Sheila, how long did it take you to trust that? To trust the
It took a while, and part of the trusting process is actually looking within ourselves and looking in the mirror, because I've had many years of thinking that it was failing, but then if you critically look at the quality of the scans, sometimes it comes down to not having good tear film, or it's off center or something like that. And so a combination of technology getting better over the last decade, where the algorithms are actually more accurate, and also learning how to take proper imaging and throw out the ones that aren't as good.
it took me a while. Like I remember
Yeah,
when I first got it, I would still question it. I would still go with my gut and say, no,
totally.
let's use a different lens. And it took a few months and few patients, and actually more than a few patients. And I would go back to see what the final lens was and
Yeah.
what first lens was, and it was very close. And
Yeah.
now, like you said, I don't even question it. We use the first fit lens as our initial lens, and we move on.
And move on with your day, go get a coffee, whatever, you know. We've got some top tips on that note of how to get good quality scans. So specifically for our profilometry and our scans that require us to get imaging that's past the cornea, we have to actually get the eyeball open. And so to do that, it actually, depending on lid anatomy, is important to position the head in a way that maximizes real estate. So if I go nice and close, more on the top, less on the bottom, more on the bottom, less on the top by going up and down. So you can actually move the patient around in the chair, pull the head back a little bit. And I do find that taking a second person sometimes with the profilometry to lift the eyelid up to make sure that we're getting really good, clean information is often better. Now, whenever we're getting scans done in the clinic for lens design, and this is, ortho-K, scleral lenses especially, not so much corneal GPs, honestly, but you have to wash the eye out a little bit. So minimum 2 days, but a lot of providers will actually say, and labs will say, if you can have them out of lenses a little longer, it's going to be better, because if somebody came in and they wore their scleral lens there, they wore it yesterday, they're still going to have an impression ring. So it's really important to wash them out a little bit and remove those lenses prior to taking the scan. Now, streamlining, so to give you a few little, took us a while, both of us, to get good clinical flow. And so some kind of highlights of our learning over time, over years, really is the bottom line is use your staff to the fullest. They're there to support you, but they don't know what to do if you don't teach them and you don't empower them. And so we have our staff are highly trained. We have staff training every Friday, and we have a special focus on contact lens on many of those days. I find that with myself included, so I'm not picking on staff, it's everybody. You have to almost retrain and revisit your techniques every so often, because we'll do training and do topography, lids, everyone's doing it perfectly. Then you get busy and it's telephone and teaching the next person. And next thing you know, scan quality is junk. Same thing happens with retina scans too. And so making sure to do regular training and checking in to see if the images are high quality, because they have to be trained to take high quality scans to have high quality output. So using software we've talked about, put a lens on before the doc comes in, cross-train on all lens types, and counseling. So your staff, you should never be doing contact lens training. I never talk about solutions. I never even want to talk about, I don't want to spend 5 seconds on it. I will actually get my staff in to do all of that. And they are the ones that have a little bit of extra time to spend to make sure that patients understand. And patients will have to have information about solutions, handling, explained to them repeatedly. Now, a couple other things, train our expert contact lens technicians. Let's see. I don't know if you can hear the volume, but you know what? This is an example of patient education. So this is my old resident, and the purpose of having that video in here is really just to show what we do for patients too. So in the clinic, knowing that this is a business, knowing that we're all friends here. We all want to lift each other up. Absolutely. That is the best way for us all to get better, is to be supportive. It's a competitive market. You want to differentiate yourself from your competitors. You got to do something to show value in the clinic. One way that we do that is to show what we're doing. So we use the tools to educate patients and teach them about why would we choose a free form that costs twice as much in the first place? You know, why am I making this selection rather than this one? And patients just love seeing the data of their own eyes in particular. In particular, corneo-scleral profilometry is very impressive looking. It looks like an eyeball. It looks like a rainbow. It's very cool, and patients just love it. And remember, it's for the cornea as well.
It's easy to understand too. Like, I mean, showing that picture of a pinguecula, like it's very much understandable to a patient that, hey, it's red, it's hot, it's deep, it's not the same as my temporal side. So
exactly. Totally. And they'll resonate because they'll be like, yeah, it's always red there. I always feel like I look like a mutant because I've got this big red thing under my lens. Everyone's asking me if I've been, partaking in things that are not healthy during the day. And yeah, they resonate. Here's a case, 38-year-old male, keratoconus, nothing really going on. Here is our lens design. And this is another cool application that we use not infrequently, is to assess not only our sag height, but how irregular our sag height is. This allows us to choose what's called bi-elevation designs, and that is one manufacturer that calls it that, but there are many different ways that we build in bi-elevation. We can also use these differences to compare different heights of that eye at different chords as well, which affect how we choose our lens design. Now, so we can finish with this last topic before we get into questions. Aberrometry. So this is kind of like the new black in the contact lens world. We're saying, what is it? Orange is the new black, or aberrometry is the new scleral topography, or something like that. But the cool thing about it is they partner together. And so by embracing tools that allow us to accurately map out the eye and create the lens shape that is the most appropriate, we can then now elevate and add on what's called aberrometry. Now, aberrometry works nicely with our manufacturers that build lenses based on profilometry. The reason for that is lenses that are based on profilometry are usually more stable because it's more like a glove fit. And in order to apply high-level optics onto a contact lens, it's got to be stable. So we start off with a really nicely fit lens, and let's just talk briefly about aberrometry. So we know, the eye is very complex. It's a multi-layer system that ultimately is all part of the one big system that creates vision for us. Now, aberrations are optical errors. We know that creates an inability to focus. And wavefront maps differentiate the difference between aberrometry values, always in the relationship to a pupil diameter, but basically between like a smooth wavefront that's not good, or a smooth image, and the non-ideal image. Now, if we describe aberration, the way that we do this is with Zernike polynomials. So if this gives anybody the heebie-jeebies in our physics classes from back in the day, that's because it can be very complicated, but ultimately this is a language used to describe aberration. And basically what we use it, the way that we apply this is splitting our aberration, or our visual blur, into two general categories. Lower order aberration, so that's the basic focusing errors. So like tilt, which requires prism, or just basic optical defocus, myopia, hyperopia, and regular astigmatism. Higher order aberration are those ones that just cause patients to have weird ghosts and halos, and details are just not in focus. And so when it comes to third order and fourth order aberration, these blurs, or we'll say this type of visual disturbance, requires a special optic called a higher order aberration corrective lens to neutralize that. These patients often have 20/20 vision or 20/25 vision. And, not all their vision complaints are because they can't see the 20/20. It's because the quality is just not good. If you look at the pictures in the light bulbs, patients will, or even this picture, I mean, for all intents and purposes, that's a neutralized lens, but they're getting aberration because some of the optic of their eye is not correctable with a standard optic. So in our practices, we actually utilize higher order aberration corrective lenses. And both of us have had a lot of success with it. And the reason we wanted to just include this in this presentation was just to give you a little teaser on what would be a whole nother lecture that really looks at how do we partner technology together. So in any busy specialty lens practice as you're growing, or even if you're just wanting to differentiate, it is an option now that partners very nicely to help to mitigate that 20/20 unhappy patient by placing HOA corrective wavefront optic on the front surface of a scleral lens. So this is really cool technology. Now, some of the patients that are not good candidates include really severe scarring, although I have colleagues that do fit HOA corrective lenses on patients that have cataracts that have some level of scar with a lot of success. Now, if we pick the best patient for HOA correction, always starts with a stable lens. So to be honest, eyes that are too regular are not the easiest because the lens is going to move around, but the very best way that we can get a lens to be stable and centered is to fit it like a glove. And that's where our shape measurement comes first. We have to do those steps, and it is the most effective in getting to this endpoint high level with HOA correction. Now, in closing, we want to just say SEG gives a true 3D model of the eye. Curvature doesn't match SEG. It doesn't always, it's just misleading. And so you really have to separate those things to be able to successfully fit. Now, this stuff is available. So the technology is not unavailable to you. We all have access now. And so these things are out there for us to take advantage of. And really, when it comes to the highest level of patient care, having these, even if you're not doing it, knowing where you can send patients to. You know, if you're in Alberta, close to Edmonton, if you have a patient, you get to a certain point, send them over to Sam when you're ready for the next level, for example, because this stuff is out there and it's really, really amazing. So in conclusion, kind of overall, profilometry absolutely cuts chair time. Aberrometry absolutely enhances visual outcomes. And really overall, by using technology in your practices, and it's here to stay, it allows us to really streamline our workflows. Therefore, it's not about the money, but it is. It's about both. We have to take care of our patients, but take care of ourselves and our building and be able to put a roof over our buildings and our families to be able to come to work every day and make sure that we're doing our best for our patients. And so it does come down to revenue. And that's where I want to make sure now that we have the time to turn over, I think, to some questions, if anybody has any questions, and open it up to Sam if you have any comments or clinical pearls or any message that you wish to share with your group. Because I know that you've been doing a whole lot of this stuff in the last couple of years, and I personally have loved seeing all the stuff you've been up to.
Yeah, absolutely. I think every clinic's journey in scleral lenses, it's a little bit different with the time and where they are in their evolution. For us, we used just a topographer, and we did the old-fashioned trial and error for many years, right? Then along came Eaglet. It took me a couple of years to bite the bullet, and talking to a lot of my colleagues, and it was one of the best decisions we ever made. Our patient, the patient base was just growing, and having too many scleral lenses the old trial and error way, it was just bogging down our schedule. So Eaglet helped shave off a lot of our time, helped improve and our workflow, made it more efficient. We are at that point where I don't have the HOA correction just yet. We've signed the contract, and I'm excited and waiting for it. But that's where we are. It took us 4 years with the Eaglet and doing custom fits before I was ready to do it. Even with the custom fits, like I'm glad that Sheila showed those images. We have a lot of patients, 2,200 prior to scleral lenses, put them in a custom lens, they're down to like 2025, but they have
Amazing.
that ghosting, doubling, and I know that there's something out there that can help them. So that's where we are. But are they happy? They went from 2,200 to 2025. They're super happy. Are they referring patients? Yeah, all day long. So, I just want to just say, you don't have to go from 0 to 100. Start somewhere. Majority of you already have a topographer. If you're on this call, you either have one or you're thinking about one. The next step really is a corneo-scleral proliferometer, and then then the ovits or another HOA device after that. But it doesn't have to be all at once. Yeah,
I love that.
yeah.
Let's open up for questions, and so you could unmute yourself if you wanted to ask any questions. I have some questions for you, Sam.
Sure.
How's your
Sure.
ROI? So what is your experience with, because you have to pick and choose what you buy. It's not all just grown on trees. And so what has the ROI looked like for you when it has come to some of the equipment you've invested in for specialty contact lens fitting?
You know, that's really hard to measure. Like I couldn't put a figure on it. I can tell you that it's you know, the instruments have been paid off multiple times over. Uh,
Mhm.
the reason why it's hard for me to give you like an exact number is for all the reasons we've kind of talked about, right? Like if you consider me, you know, shrinking my scleral lens new fits from an hour of doctor time to 30 minutes,
Mhm.
right away I got
Yeah.
two slots right there, right? So that's further revenue generation. My follow-ups from 45 minutes to 15 to 30 depending on
Mhm.
the patient. Again, more slots open. Happier patients, you know, referring others, you know, happier referral sources. Like I have a you know, a very large ophthalmology practice that refers, I want to say pretty exclusively to me just because of their patients being super happy. And you know, when I was doing the old-fashioned way, the trial and error, just with the topographer, you know, doing some quick math, empirical fits, like I was no different than, you know, the guy down the street.
Mhm.
The eaglet really helped, you know, define my scleral lens practice. Yeah. So I don't know. I can tell you I paid it off multiple times over.
Yeah.
You know, I went from one fitter to now we have a Dr. Lee who joined us a few years ago, and you know we have other doctors who, you know, see what we're doing and they're interested. Uh,
Mhm.
yeah, I don't
I
know.
love that on the freeing up your chair time, because even with
Yeah,
our resident, I find it's hard to track exactly, although overall the numbers just go up because by
yeah,
freeing yourself up to see more, even more eye exams, for example, or more of whatever, just rather than spending your time doing
yeah.
the measurements and doing things, it just ultimately it just makes it all better. So here's a few questions. So how often do you have to generate a second or a third lens? So when you fit sclerals?
So with the custom lenses,
Oh, and as compared to before the technology. So
okay,
what's your experience?
fair
And then
enough.
I'll share mine.
Fair enough. So without the eaglet, I for sure three, four. I think
Mm-hmm.
I talked once at the, you know,
Just
GLSL.
LS? Yeah, yeah.
It's a mouthful. We talked once, and I remember telling you I'm like a three or four, and you told me
Yeah.
you're lower, and I was like, how? And I think you said eaglet, and that was it.
So it's very subjective as how like fits, but on average, I've definitely seen a huge decrease in especially the comp like well actually all shapes, but some of those ones that would have taken like many fits, they're getting edema, there's like failures. That just really goes down when we can identify that shape early and
Yeah,
then build a lens that has the highest safety fixtures right off the bat. Man,
yeah,
that goes in spades. It's faster to fit and the patient just does better anyways. So
yeah,
overall, there's no study that supports this. Trust me, I've looked and we talk about it a lot in our circles. It's like it's just a hard thing to put a proper study together for. But overall, definitely fewer remakes on average. How many scleral patients a month would you say would give you a quick return on investment with the eaglet or another device?
so by having the eaglet, you know, it opened up my options. So you know, different custom lenses. I
Mm-hmm.
primarily one in the States, I print, I think they're Wave now. So the Scan Pro lens, without the eaglet, I was not able to, you know, but to fit that lens, we charge, I want to say off the top of my head, I think $700 more for the lens than just you know, conventional scleral. Uh,
Mm-hmm.
so call that 1,000, 1,200 bucks just
Mm-hmm.
by having that optionality for the lens. And we
A patient you would have fit in a standard lens, you're now fitting them with less chair time in a more sophisticated lens, and you can share that value and explain to them why it costs more because it
absolutely.
just is better. It's like I don't know if you're into cars, but I use car analogies sometimes. I drive a Toyota, go right into the whatever you're into, the Cadillac or whatever it is.
So we also charge for scans too. So tack on another 250. So
Mhm.
so overall you're about 1,250 to $1,500
Mhm.
per patient
Mhm.
more. So what is that? 10, 12 patients
Adds
now?
up fast. Yep. So then to put it depends on what the price is on the device, what you work out and what device you choose.
Yeah.
But I would say to answer that specifically, so I don't know if you have like 5 new fits a month or something like that, looks
Oh yeah.
like
We for
easy
sure have,
peasy.
yeah, we have five. And you know, the thing is these keratoconus patients or corneal pathology or trauma patients,
Hmm.
they, you know, they're all in forms or they're that, you know, they have groups, and you know, you fix one bad fit or you make one of them happy, you know, they're referring another person. uh,
Hmm.
And like I was mentioning, we got the eaglet and the ophthalmology practice that we deal very closely with.
Totally.
Saw happy patients and they kept sending us more. So I would say, yeah, if you can get 2-3 a month, within 6 months, you'll pay it.
6 months, 12 years, or 12 years, 12 months. 12 years would be a long time to get the money back. And I love where your head's at with that, because I would argue that it's just as equally or even more so sometimes for bottom line and revenue generating and patient generating is the technology itself to give you that referral pathway. People will send people to you. It's impressive. You can advertise it. And so I think that is just as important as the actual fit itself when it comes to overall what builds the practice.
Yeah, for sure. There's really no price I would put on, peace of mind when I see it.
No price on happiness.
Yeah. So for me, I would equate this as, we had fundus imaging and then we got OCT, and would you go back and, see patients without an OCT? Probably not.
Totally.
I don't think I would, do scleral lens.
Ortho-K used to be fit with no topographer,
Yeah.
I mean, that sounds funny now, but it's like that's the reality, and that is where we're headed. I've said this for years. It's analogous, like it is
Absolutely.
the same. And our digital design is just it takes over. And again, to also remind us, that does not take away the responsibility of educating yourself, getting experience. And the beauty of having digital design is that we can then free our minds and intellect to look at complications and spend more time with the patient, with their goals and things like that we talked about.
Yeah, absolutely.
Great. Well, 7 o'clock on the dot. I will just offer for Tara or Elena to hop in if there's anything that they would like. Just interrupt me, and anything last that you have for the group, Sam, or you could probably close if you're ready.
A lot of the names here I recognize, and feel free to reach out even offline if you have any questions. Yeah, like I said, it's a great piece of equipment to add to your artillery.
Great.
Thank you, everybody, for coming to the All Docs educational program this evening. I hope to see you all at one or both of our All Docs meetings this year. Thank you, Dr. Dhaliwal. Thank you, Dr. Morrison. It's been a pleasure.
Awesome.
Thank you.
Thanks for having us. Yeah.
Oh, and thanks to Elena and Tara. Oh my gosh. Thanks, you guys. Take care.
You're welcome. Good night.
Good night.